and welcome to this important International AIDS Society and Love Yourself media briefing on the HIV AIDS epidemic in the Southeast Asia region. My name is Michael Kessler. I'm a media consultant with the International AIDS Society, and we're delighted to have our speakers join us today, and also the journalists who are attending this session. I also understand there are a number of people from civil society and from academia who are also sitting on the call, so a warm welcome to all of you as well. Before I make some very brief introductory remarks and then hand it over to our esteemed experts, speakers, I just want to go through a few house rules for everybody. Starting with that the session here is being, obviously is live, but it's being recorded. If there are any journalists who are attending this session and would like to get a recording of this, we will be sending the recording to everybody within the hour, 2 hours of the briefing finishing. Also, I would just like to say that everything in this media briefing is on the record unless one of the speakers indicates otherwise. This is all on the record. It is quotable. It is for reproduction, whether that be broadcast, print or online, just so you know. The run of show today will be briefly myself making some very introductory remarks to set some context for why this briefing is happening today. And then we will hand it over to our speakers. Our speakers will speak roughly around 5 to 7 minutes each on their particular topic, and then we'll open it up to questions from the journalists. You can send your questions in through the chat box, which you'll see below your screens. Please, when you send your questions, make them short, to the point. Please indicate who you want to ask the question to, and please indicate which media outlet you are from. That's important for our speakers to know, and then I will read the question out and direct it to the person that you've asked the question of. If you do wish to, and this particularly applies to broadcast media, if you do wish to ask a question verbally, that's fine. Put your hand up with the raise your hand icon, and we will unmute you so that you can ask the question. But again, please indicate when you speak verbally about, please indicate who it is you are asking the question of. And keep the question brief, and also indicate which media outlet you are representing. And the last point I would say in terms of house rules is that if you do want to speak to anybody on our panel today after the event and you haven't had a chance to speak, ask a question, or you want to speak in more detail, that's fine. We will try and arrange that in the next 24 hours. You've all got my email address. Just send me an email and let me know who you want to speak to, and we can arrange a one-to-one interview with that person between now and tomorrow. So I think that's it for the house rules. Before I introduce speakers, as I said, I just want to make a few very, very brief comments in terms of setting some context of this meeting. This meeting is brought to you by the International AIDS Society and specifically the International Education Fund, which was set up by the IAS 5 years ago and jointly being held by our partners in the Philippines, Love Yourself, which is an amazing civil society organisation working around HIV in the Philippines. If we were not in a virtual world, we would perhaps also be in Manila today. But unfortunately, that's not the case. The one advantage to that is the fact that we are able to invite a whole lot of people from across the region, and I'm delighted to say that I see journalists here from Thailand, Malaysia, Singapore, Indonesia, and the Philippines. So that's fantastic. That's one advantage of being virtual. The reason we're holding this media briefing is because the International Education Fund generally speaking, holds a number of meetings each year to focus on particular parts of research, science and implementation in particular parts of the world. And the way they do that, they generally hold a 2-day symposium in a given city, and then invite local researchers, academics, practitioners and community representatives to that symposium to deliver presentations on their particular speciality related to the epidemic in the region. That meeting would have happened in normal circumstances in Manila, but as we all know, we're doing this virtual. That meeting is happening in parallel at the moment over the next 2 days. And the panelists that we have today and tomorrow reflect more or less the gist of the sessions being held in that meeting today and tomorrow. The other context of this meeting, of course, is, I think, an important one, and that is that we are 2 days away from the 40th anniversary of HIV AIDS, from the first United States notification of an AIDS case on June the 5th, which is this coming Saturday. So I think that is indeed a context for this meeting. We kind of deliberately try to make it before that landmark. I think that sets the scene for what we might talk about today in terms of looking back, seeing where we've come and where we might be going in the future. You'll notice behind me, apart from the IS logo, there is actually a podcast logo, and that is in commemoration of the 40th anniversary. The International AIDS Society is actually producing a 15-part podcast series to commemorate the 40th anniversary. And I strongly recommend everybody, speakers, journalists, civil society and community, to listen to the podcast. The first episode was broadcast 2 weeks ago and features the one and only Dr. Anthony Fauci, who needs no introduction, and is a brilliant recap of the very, very early days of the HIV/AIDS pandemic in the United States, but also globally, and features a number of community representatives and other researchers. And I know that the next edition will be running very, very close to the upcoming United Nations high-level meeting on AIDS, which is happening next week between June 8 and June 10. And I think the significance of that meeting also produces a bit of context as well. As you may know, it is now 20 years since the United Nations special session on HIV/AIDS that was run in 2001. Why do I mention that event? That event was incredibly significant because it changed the landscape for HIV/AIDS around the world. Antiretroviral drugs were not getting to other parts of the world like Sub-Saharan Africa, nor Southeast Asia, or South Asia for that matter. And that United Nations meeting, general special session, changed the landscape in terms of it led to the impetus, the momentum to create the Global Fund Against AIDS, TB and Malaria, as well as the presidential PEPFAR fund in the United States set up by George Bush and Dr. Anthony Fauci shortly afterwards. And the result of that, of course, has been a huge transformation of the AIDS pandemic in terms of people getting access to antiretroviral drugs across the world. So the significance of next week's meeting on top of the 40th anniversary is very, very significant because it is 2 decades since that United Nations special session meeting as well. And as you will have already seen in the news, there's also quite a lot of news happening around the anniversary, but also around that United Nations meeting that is happening next week, which will bring together health ministers and world leaders to discuss where we go next with the AIDS pandemic and what the targets will be for 2030 and beyond. I will finish there and introduce our first speaker. Our first speaker is Dr. Iskandar. He is Associate Professor at the Centre of Excellence for Research in AIDS, otherwise known as CERIA, based at the University of Malaya in Kuala Lumpur, Malaysia. Dr. Iskandar is going to talk briefly, give an overview of the HIV/AIDS epidemic in Southeast Asia, and perhaps also focus on a few prescient points around the epidemic in his home country of Malaysia as well. Over to you, Iskandar.
Thanks very much, Michael. So I thought we would just set the scene to discussions that will follow after this. And talk about overview of the HIV epidemic in Southeast Asia. I'm going to broadly talk about the issues around the Asia Pacific, but with a focus more specifically around Southeast Asia. So we have about, from 2019 data from UNAIDS Data Hub, with 5.8 million people living with HIV, of which 3.5 million are receiving antiretroviral therapy. There were 300,000 new HIV infections in 2019, of which India and China formed the largest number of new HIV infections. So India, 28%, China, 29%, followed by Indonesia, 16%, and Philippines, 5%. over the past 9 years, there's been a 10% decline in new infections. But however, the decline in infections has been stalled, however. Most countries have seen decreases in new HIV infections between 2010 and 2018, apart from Malaysia with a 4% increase, Pakistan a 57% increase, and Philippines here a 203% increase. Hence, it's important to focus our regional efforts within the Philippines in particular. Breaking this down further, looking at the distribution of new HIV infections by the population aged 15 to 64 in the Asia Pacific in 2019, the majority of these new infections are occurring within gay men or men who have sex with men, 44%, followed by clients of sex workers and partners of all key populations, 21%, and people who inject drugs, 17%. Hence, an urgent need for a very much focused response where the epidemic is mostly concentrated within key populations and their partners. HIV in Southeast Asia is concentrated also very much in cities. For example, in Malaysia, and this is data from the Integrated Biobehavioral Survey, in 2017, the national HIV prevalence among MSM reported by the Ministry of Health was 22%. This contrasted significantly with what was reported in Kuala Lumpur as high as 43% of HIV within MSM. There is an urban growth and rising HIV epidemics across the region, particularly among young MSM. In Kuala Lumpur, 1 in 3 young MSM are HIV positive. This is also largely driven by digitalization, increased connectiveness to social media and dating apps, and looking for a safer space in the virtual place. When we look at the HIV incidence, in those using geosocial networking apps, we find that the HIV incidence there is at least 2 times higher. 70% of MSM who use, say, social platforms to find sexual partners are in the age group of 18 to 25, so representing a younger age group, and this is based on an internet survey of Vietnamese MSM. But ultimately, what we do or what we can do better within the region is HIV prevention. There is a huge HIV prevention intervention coverage within the region. Resources are generally channeled by ministries of health to treatment across the region. And therefore, this reduces resources for innovative prevention innovations. For example, in Philippines, there is a 28% coverage on HIV prevention in MSM. Malaysia has a 58% coverage on HIV prevention in transgendered women. Looking at a different key population, Malaysia does well in terms of opioid substitution coverage of up to 74%, compared to, let's say, maybe Thailand, who does better in other areas, but not so good in opioid substitution therapy coverage of about 5%. HIV testing coverage also among key populations is generally suboptimal, with half of key populations not knowing their HIV status. 54% of MSM between 2014 and 2018 report having tested for HIV in the last 6 months. Countries also lag behind more community-based models of HIV testing. So 53% of countries across the region are allowed to do community-based HIV testing, 32% lay provider testing, but only 11% carry out HIV self-testing. Moving on to treatment targets and gaps, and this is a regional overview from 2019, something that UNAIDS data is particularly interested in. Across the region, 75% of people living with HIV know their HIV status. 60% of people living with HIV on treatment, and 55% of those who are on treatment are virally suppressed. But ultimately, it also depends on what laws you have, which are supportive on impeding the HIV response within the country. All 38 countries in the Asia Pacific have laws that impede HIV response. For example, 37 criminalize some aspect of self-work. 11 have compulsory detention centers for people who inject drugs. 15 have death penalty for drug-related offenses, and 16 criminalize same-sex relations. 10 impose some form of HIV-related restrictions on entry, stay, or residence, so leading towards a general growing conservative political environment across the region. Ultimately, also, government expenditure in the AIDS response, as I mentioned, largely goes to treatment. And there's a great need to increase key population prevention services, which rely on external funding resources, external financing resources. And there's a huge need for increasing domestic funding of key populations and civil society organizations to address this huge prevention intervention gap. On a more somber note, chemsex, which is the use of drugs for the purposes of sex, is not a widely discussed within the media. It is a universal phenomenon across men who have sex with men within the Asia Pacific region, and is possibly driving the HIV epidemic, particularly in young MSM. 5 to 15% of MSM within countries across the region report use of drugs for the purposes of sex, particularly crystal meth, in the past 6 months. To conclude, and this is probably my last point and maybe room for discussion later, ultimately, the HIV response within countries are largely leveraged on stigma. And stigma, like in other countries, in other parts of the world, is a major barrier to HIV services for key populations. And we must do more in terms of developing and adopting evidence-based interventions for key populations across the region. Thank you.
Thank you, Dr. Iskander. Our next speaker, just before I introduce the next speaker, I did want to make the point that this is the first of 2 media briefings, and that tomorrow we are focusing on the impact of COVID-19 on the HIV epidemic in the region. And I would say that when we did first start thinking about it in this media briefing some months ago, we didn't know then what the pandemic would be looking like now in the region. And obviously, the relevance and the resonance of tomorrow's session is going to be even more so because of what is occurring with the surge that's happening across the region, and particularly in countries like Malaysia and in Thailand. So my reason for mentioning that is that if you do have questions around COVID and HIV, we will be addressing that tomorrow. I think it's kind of hard to avoid the issue when it comes to questions today, but we would prefer that those questions be left for tomorrow. The point of today's session is to kind of lay the groundwork, understand what the epidemic looks like, generally speaking, and then talk about what the impact on that epidemic will look like because of the COVID pandemic in tomorrow's session. Okay, our second speaker is Danvik Quazadinho. Danvik is the Director of Operations and Research at the Love Yourself organisation in Manila in the Philippines, who are partnering with the IF meeting this week, and also this media briefing. We're delighted to be partnering with such a wonderful organisation as well. And Danvik is going to give a bit of a snapshot of what is happening in his country, in the Philippines. Over to you, Danvik.
Thank you so much, Michael, and good day, everyone. In the picture of the HIV epidemic here in the Philippines is, as mentioned by Dr. Iskander earlier, it is actually experiencing a fast and furious HIV epidemic. As of April 2021, there are 86,771 Filipinos who were diagnosed with HIV in our country. And the cases per day that are diagnosed as of this month is around 33 cases per day. And coming from that picture, if we will be zooming in further with how the picture of the HIV epidemic in the Philippines, most of the diagnosed cases are transmitted via sexual transmission, which is accounting for around 85 to 90% of the cases in the Philippines. And there are many reasons on why these happens, because it's a good thing and a bad thing. We always say that data is always a double-edged sword, and it is a bad thing because, as we can see, it estimates show that the epidemic is fast rising and there are still many underdiagnosed. In fact, according to a report that was released by the UN AIDS, as of December 2016, only 67% are diagnosed for all those who are estimated people living with HIV in the Philippines. But it's also a good thing because the fast rising number of cases, remember, these are people who are diagnosed and they went they went themselves for testing to not only the government but also other community-based organizations who are working cap in hand in providing HIV-related services. But of course, we need to do so much, especially in terms of diagnosing people, because there are many concerns on why Filipinos are still underdiagnosed in the Philippines, because there are barriers on why people doesn't want to go for an HIV test. Of course, there are misconceptions that downplays their need to get tested. They said that they don't, some of the clients say that they have no time to do it, or there's no there's no urgency specific related to HIV. Of course, in the Philippines, where it is a conservative country and mostly we view sex as a taboo, morality plays a factor on not for them to test for HIV. There are some people saying that they feel morally superior to other gay men, or the idea of being seen to be tested for HIV is embarrassing, or their behavior is immoral, coming from the concept that sex is taboo in the Philippines. Of course, there are also clients who worries about confidentiality and privacy. They are concerned if they will know that their result is HIV positive, or they might give malice on the entire testing concept, where they might their partners might judge them based on their HIV test results. And of course, that relates to some of the clients who has fear of what happens when they test HIV positive. They may be, some of the clients worry that they might, end up being the only person with HIV in their close circle of friends, or they might fear losing support from their family, peers, and other people if they found out that they are HIV positive. And of course, there are other factors that are related to HIV testing services in itself, providing the reason why they do not go for an HIV test. Of course, some of them are location-based, Philippines being an archipelago and with different topographies of land. The testing center may be far away and closely confined in major cities. And maybe there are other clients who says that the testing time takes too long. That's why what we did in Love Yourself is that we introduced innovations so that we could bring HIV testing to more people in the Philippines. And one way for us to bring HIV testing to more people in the Philippines, especially during this time of COVID pandemic, is to bring the concept of HIV self-testing to the community. So what we did in Love Yourself is we did a demonstration project, which we call Self-Care. The Self-Care project assesses the acceptability and the feasibility of HIV self-screening among men who have sex with men and transgender women in metropolitan Manila of the Philippines, where around 60% of the epidemic is concentrated here in our country. The demonstration study that we did is divided in two phases. The first one is the formative assessment, which this phase serves as a foundation of our implementation on how can it guide us in delivering the service to our community. And of course, the phase two explores the demonstration project itself, where we will be procuring and delivering test kits to the community via an online-based approach. So what we have discovered in the study, in our phase one, in terms of knowledge, most of of our participants are aware about HIV self-testing, around 49.66%, and they are aware that they are available already in the Philippines. In the Philippines, the context of HIV self-testing, while it is not available formally, there are other online shopping networks where they're offering HIV self-testing kits that are actually not WHO pre-qualified and do not have a registration from the Philippines Food and Drug Administration. And they are aware of its presence. In terms of acceptability, our clients are almost all of them, 97.42%, are interested to use self-testing as an alternative approach for them to know their status. And in the Philippines, most of our clients prefer a blood drawn method, around 60.77% of our respondents. In terms of marketing and distribution, since the Philippines is an online-based country, well, Facebook is the use of Facebook and other social media platforms are very prevalent here in the Philippines. Most of our clients wanted to order it online, around 75%, and want to have it delivered at their homes. In terms of monitoring and tracking, what we have seen to our clients is that most of them are likely to report their HIV test result, 87.82% if they are non-reactive, and 88.93% if they are reactive, and they are likely to confirm their HIV test results within a week. And that's around 83.12% of our respondents. In terms of the support needed, we have to take note that HIV self-testing needs to have a confirmatory test so that you will be confirmed HIV positive. With that, we encourage our clients, once they receive their HIV a reactive status for their self-testing, we encourage them to go to our community centers for them to access their confirmatory testing. In terms of the support needed, according to our feasibility study, most of the non-reactive clients would be needing remote counseling, which is around 39.11%, and on-site counseling for those who are reactive, which is around 51.29%, which is a good thing because if they will be needing on-site counseling, that would mean that they would be accessing their confirmatory tests, in not only in our community centers, but also in other HIV testing facilities. After determining the results of what I have said in phase 1, it has influenced us on how to offer our demonstration project, which we offered around 1,690 test kits to the community, and around 1,281 have reported their results to us. And what we have seen from 1,281, 94 clients turned reactive, which translates to 7 to 8% reactivity rate. And what we have seen in the demonstration project is that this is an alternative approach to offer and bring HIV testing to various communities in the Philippines. So moving forward, we wanted, since there is already a registered brand of HIV self-testing here in the country, we would want to leverage on that certification and offer it to more locations in the Philippines and introduce other methods in terms of providing HIV self-screening, in particular using a oral-based method in order to, to bring them the HIV testing to clients who are actually scared of getting pricked by needles or actually scared of blood. So it's really it's very important to consider the needs of the community so that we will be able to provide a differentiated care approach to each and every one of them so that we can reach everyone and we can help them based on their HIV test results, whether they're HIV negative or HIV positive. With that, I thank you for listening to our story.
Thank you very much, Danvik. That was very, very interesting. And I think it also throws up a lot of questions for tomorrow's session on how this is kind of, COVID has impacted on this as well, because I know there's been stories globally around, ironically, increases in self-testing because of the pandemic. So that's given us a lot of food for thought. Thank you very much. Our third speaker is Nataya Frantulfar. I hope I got that right, Nataya. She's a member of the IS Governing Council for Southeast Asia, and she's also the Executive Director at the Institute of HIV Research and Innovation in Bangkok, Thailand. Nataya is going to talk to us briefly today around same-day initiation of antiretroviral therapy and also undetectable equals untransmissible too, and what the implications are for Thailand and more broadly in the region. Thanks, Mikaya.
Thank you, Michael, and also thank you, Iskandar and Danvik, for set the stage of how we really need to work much harder and quicker in order to end the HIV epidemic in our region. And I have to say that although like my part is about ART and about U equals U, but I really want to emphasize that for now, we shouldn't think about HIV treatment in a separate way to HIV prevention. And I really would like to propose that in any place that we are doing our role in addressing the HIV epidemic, we will need to use the status neutral approach lens. That means that we put equal importance to clients coming into our service for HIV testing, regardless of their HIV status. So for those who come in and tested HIV negative, we will need to offer PrEP immediately as part of the combination HIV prevention package to make sure that they can maintain their HIV negative status. And at the same time, once a person tested HIV positive, you also need to offer ART immediately in order for them to achieve the U equals U goal of having zero risk of transmitting HIV sexually to other people. And by having these goals in mind, having the zero risk of sexually transmission of HIV among HIV positive individuals and having almost zero risk of HIV acquisition among HIV negative individuals, I think it will make our work much more exciting, because we know that each person coming into our service, we really need to get them, support them towards each of these two goals. And so just for that, then the treatment part, the ART part, I think it's very similar to the PrEP, the prevention part, that over the past 5 years at least, we have seen that ART initiation has become much easier comparing to the past through the simplification, which means that you reduce the steps, you make steps less complex, and also through differentiation, because now we know who are the clients who we will need to provide a light service, and who are those clients who we may want to provide an intensive service. So it's not like everyone in the same box that we need to provide the same level of intensiveness of the service. Right. And also through demedicalization is another thing that Danvik has mentioned about that a bit for HIV self-testing. For PrEP in our region is also demedicalized. For ART, I think we are going towards having ART initiation and ART refill be more and more demedicalized as well. So by saying that, at least in Thailand, we have started the pilot of same-day ART initiation in Bangkok in 2017. And we have gathered very beautiful data that resulted in same-day ART being expanded to a few other provinces over the past few years. And just earlier this year, same-day ART initiation has been put into our national guidelines. And by saying that, it does not mean that having guidelines is the end of everything. We finish our work. No, because we can see that the results of implementation has varied quite a lot from one province, one hospital to another province, another hospital. If we look at the data from Bangkok, we can see that we have been able to start ART within the same day of HIV diagnosis in 80% of people. And the rest, almost all of the rest, started ART within the same week of HIV diagnosis. That's Bangkok. But outside of Bangkok, we can still see that 15 to 20% of people who started ART have their ART started more than a week after diagnosis. So this is something that's quite contrary. And the only difference here is that among HIV testing sites, which are mainly key population-led HIV testing clinics, like the one that Love Yourself just described, and ART sites in Bangkok. Both providers in these testing sites and ART initiation sites used do equals you message as the main motivational message to communicate to people, to make them feel that they want to start ART and they want to stay on ART. And I think that's really important, because as we can see, and we heard from the panel discussion today, I think even among a large organizations working with people living with HIV in some countries in our region, we actually don't have enough knowledge or enough confidence in communicating U equals U to get its maximum benefit. And you can see that there could be kind of some conservative way of communicating U equals U in a way that it's not zero risk, it's just minimizing risk. It's still a lot of concern around unplanned pregnancy and STI, etc., etc. But I feel that that's why we really need to look at U equals U in a way that we need to get over just a superficial campaign of showing a backdrop or a poster of U equals U. It's not enough anymore. We should realize now, and it needs to. We need to get to the stage that we really plan towards having U equals U be implemented by healthcare providers and be aware of and be requested by people who are living with HIV. And this may need to be through methods that can reduce stigma related to U equals U, which is somehow be certain stigmas related to sexual context and condom use, I would say. And by saying this, I really would like to encourage that countries in our region may have to think seriously about adding U equals U in certain documents that providers or people living with HIV in your country will refer to. The experience that some of you may have been part of getting U equals U language into the UNAIDS political declaration actually demonstrated to us that it's very sensitive to many other countries who still want to add the ambiguous language into a simple zero risk transmission of U equals U and modify it into minimized risk, modify it into something that needs regular routine viral load testing every 3 months, and that more research are needed, which is untrue. So here we may need guidelines, we may need education, and we may have to accept that U equals U language may be new to many people, and it may take time for some people to trust this language and to know how to communicate this language. So guidelines, training, and maybe scripts for healthcare providers to understand how to communicate U equals U correctly without modifying the language should be. I may want to end here and then welcome questions during discussion.
Thank you so much, Nitaya, and I think that was a really, really good setting of the scene of U equals U. I think that we could talk about U equals U for a long time, so I'm hoping we get some questions around it as well. So thank you for that. Our next speaker, I'm delighted to introduce, is Gemma Samitpol. Gemma is the coordinator of the Tangerine Clinic in Bangkok, Thailand, who do extraordinary work around transgender health. I'm delighted to have Gemma here to talk about the work that their clinic does, but also to talk more broadly speaking about the issue of stigma. Thanks, Jenna.
Thank you so much, Michael, and good afternoon, everyone, once again. I am sort of assigned to talk about stigma around HIV, PrEP, and U equals U among the trans people, right? I'm not going to be talking about what we face, as a trans person, because I think it's a repetition. We heard it too much already. I'm just going to talk about how we address it and how we work through our work at the Cancerine Clinic. So the first thing is HIV. I spoke this morning or this afternoon about the work on HIV at our clinic. We opened the clinic 5 years ago. And when we opened the clinic, we had a community consultation, and according to from the community, they wanted a clinic to be a transgender health clinic more than just an HIV and STI clinic. And that's how we positioned itself from the beginning. And the good thing about that is that when we say that we are the transgender health clinic, we leave the options open to people. So they can come in with many reasons. It doesn't have to be just HIV and STI. They can come to see us if they have any health issue at all. And then when they come to see us, of course we address their health needs as a priority. And then we can always integrate HIV and STI into the services that we offer them. And this model has been proven to be working in our setting in Thailand, in the way that we have seen that more than 90% of our clients had HIV testing with us, and that includes the first-time tester as well. And so far, we have served more than 4,000 transgender people in Thailand, and mostly in the Bangkok area. And also about PrEP, we all know that the uptake of the PrEP among transgender women is really low, and it happens in Thailand as well. And when we compare the PrEP awareness among the men who have sex with men and the trans people, the transgender, especially transgender women, have a very, very low awareness about PrEP. They don't know about PrEP at all. Most of the people come to the clinic with no idea about PrEP. And we were trying very, very hard to increase the awareness and also to get people to take PrEP. At our clinic, we're quite lucky that we have the supply of the PrEP. We can do PrEP. We can offer PrEP for free. We have the funding. We have the testing as well. But then again, the PrEP uptake has been really, really, really low. So last year, we finally made a big campaign called PrEP in the City that I mentioned earlier. The PrEP in the City is actually designed to target the transgender women that live in the city. We did a video that we supposed to make it as a viral, and we post this video on the social media. We also screen the video on the SkyTrain and on the underground. And we also have poster wrapped on the buses, a few buses that running around the city of Bangkok so that we can send the message out. And that was actually a big challenge for us in the way that we all know that PrEP comes with the stigma. So trying to advocate it, trying to arrest the awareness with it, especially on the trans people, was a very, very big challenge for us. One of the things is that we have been turned down by some of the buildings that we were planning to actually show our video and the poster because of the stigma around PrEP, stigma around the trans people. But we fought so hard to actually did it finally. And then together with all the technique that we developed about the framing PrEP counseling, we saw the significant rise in the PrEP uptake number at our clinic and also with the CBOs that we work with last year. And we are continuing to do that work this year. And it's going to be like an episode 2 of the PrEP industry. It may be a PrEP in the country so that we can scale up sort of, and demand. What is it? They generate the demand, right? Generate this demand for the PrEP using among the trans women. And I know it's very hard because I don't think anyone has done that before in Thailand. But still, we still are very hopeful that we will see the rising in the awareness of the PrEP among trans women. Okay, and also with the U equals U, I mentioned this morning that U equals U is great for counselor. I'm a counselor myself. I have to see the clients, and it helps in the way that you can actually help the clients to set the goal, to motivate them, that if they can reach that that point of U equals U as, as soon as they can, then they be fine. And the people that they love, their partners, their family be fine as well. And I want to share, this morning we have one question from Dr. Iskandar that I really wanted to add to this. Is my own experience about U equals U as a counselor. So I had one of these client, she's a trans woman, and she was brought over to the clinic by her aunt. And you know what her aunt said to me? She said that I took this person here to get HIV testing today. And if we found out that she had HIV, then we gonna have to leave her here or anywhere. She can't go back home. Because in the family, they have like elderly people. They have kids in the family. And they had no idea about the U equals U, and finally found out that the person were HIV positive. And U equals U actually saved my life on that day. In the way that I don't have to take care of that person, because the auntie is saying that she's gonna leave that person at the clinic. She's not gonna take that person back at home. But then, it took me like an hour to actually clarify and convince them that U equals U works well, and you don't even have to worry about it. So even if this person, has HIV, but then again, together you can work together to set a goal together. That as soon as you have, the U equals U, it will be fine to all of you. There's no worry at all. And it's also good for the people that actually planning to have kids. So it actually works very well. It's only the thing that Dr. Nitya just mentioned that, the government doesn't actually have the clear policy or message that we can use. And lots of people do not know about U equals U. So if they can raise the awareness among us, then it can actually, it will take a lot of work out of us that we don't have to maybe work that hard and take a long time to actually explain about that. The other thing that I was talking about was that the related issues that comes with the U equals U is about the treatment and how difficult it is to actually do the index testing among the trans population. Because I mentioned, like, in the country where we live, like in Thailand, where we don't have gender recognition law, where we don't have equal marriage, and in some country with some kind of, specific culture or even religion, where being trans is seen as something wrong. And that poses all the stigma to the partner of the trans people as well. And ever since we've been working at the clinic, I can say that the hardest thing to do was to reach out to the trans partner, to get them to come back to test. I've rarely seen, they come as in a couple, or even it's as friends or something, to come to the clinic. But you can see, like, the cisgender couple, they can go to clinic together. They often do that, but not with the trans people. And I've been working for like 1.5 years. I can tell that it's a very, very rare. We even try to actually get the information out of them by leaving like a questionnaire or form, something that people could pick up and see if anyone will give us any information. But then again, when it comes to have anything to associate with the trans, like having a relationship with the trans thing, people don't want to be seen, don't want to have anything to do with that, or the partners don't want to come out. So this is a big, big gap that we have to fill. And that would be me. Thank you. That took such a long time, so sorry. Thank you.
Thank you so much, Gemma. That was really, really informative. I've got a couple of questions I want to ask you later on as well about the PrEP campaign, because that sounds like really, really interesting. I'm curious what the results of that campaign were too, as I'm sure a number of the journalists will be as well. On that note, I see that there are questions coming in now from Indonesia, from Philippines, and also from Malaysia. And one of those questions is around the PrEP campaign. So we'll get to those shortly. After we have our last speaker, Andrew Gulick, speak. Andrew is also a member of the IS Government Council for Southeast Asia. He's Professor and Program Head of the HIV Epidemiology and Prevention Program, based at the Kirby Institute in Sydney, Australia. Andrew's going to talk about the rollout of PrEP in Australia and what the implications for that might be for the region. And I'm personally curious about this too, because I know that initially in the very early stages, PrEP was very, very slow to roll out in Australia. So I'm curious to hear where that is now. Over to you, Andrew.
Thank you, Michael, and thank you to the previous presenters for really fantastic presentations, which have really covered the spectrum of HIV prevention, but mostly with focusing on the testing, the treatment, and then we've just heard a really elegant presentation from Kritima about the essential role of stigma in often stopping access to prevention. And I think until we properly address stigma in the healthcare setting, we will have a great deal of trouble having more effective HIV prevention responses. But my presentation is going to focus on pre-exposure prophylaxis, or PrEP, so one pill once a day to prevent HIV infection. And I think the reason I was asked to talk at this symposium on Southeast Asian responses was because Australia has rolled out PrEP to probably a greater extent than anywhere in the world in terms of penetration of key affected populations. It's not to say that there aren't some good things happening in Southeast Asia. Nidya in particular could tell us a lot about pretty large scale projects happening in Thailand. There's also some early stage rollout in Vietnam and demonstration projects in a number of countries. But really not much in the way of population-wide rollout to a high level, which is the way we decided to do it in Australia. And the reason we wanted to do it that way is that when you roll out PrEP, which is essentially 100% effective when taken as prescribed to a key affected population, and the main population at risk in Australia is men who have sex with men. If you roll it up at scale, the modelling tells you should be able to have a rapid impact on your epidemic. So it doesn't just help the individuals, but it also has a population level effect. So in New South Wales in Australia, we rolled out PrEP very quickly over a period of about 2 or 3 years. Over that period, we had about 10,000 gay and bisexual men commence PrEP. And when you get that many people on PrEP, it acts somewhat like a vaccine, in that for a person taking PrEP, they don't become infected. That prevents them, but it protects them, but it also, of course, prevents them from passing it on to anyone else while they're still taking PrEP. Unfortunately, it's not permanent like some vaccines. You do need to keep taking it, but it can disrupt transmission chains in that way. And so after the first 2 years of rolling out PrEP in New South Wales, and I should say it is a setting where it's already had high levels of HIV testing, high levels of treatment as prevention, and quite a lot of promotion about U=U as well. So 2 years after we started rolling out PrEP, we saw a 30% reduction in new HIV infections statewide. That's not in the people taking PrEP. We didn't see a single case of PrEP failure in our study, but across the state of New South Wales, we saw a 30% decline, and even bigger declines in parts of the state which were best resourced in terms of education. So in inner Sydney, for example, which previously had been the epicenter of the HIV epidemic, HIV is really becoming quite rare. We are, like many people in the world, seeing some populations left behind, and in our setting, it's overseas born people, particularly those who have been arrived lately, and gay and bisexual men who don't identify as gay. We've still got further work to do on PrEP, of course, but it really has become a very, very popular method of staying safe in Australia. And the promotion about it has been not only about the protection from HIV, but the fact for many, many gay men, it's removed the anxiety about having sex. People, a population which has grown up with the fear of HIV, sees going on PrEP as a way to improve their sex life, as well as removing the risk of HIV. In terms of what I think really worked well in Australia and what enabled us to do this, it certainly was extremely helpful to have leadership at the governmental level, the policy level. The policy levers were all in pointing in the same direction, trying to end HIV infection. There was real support from government. I think in settings where you have less policy support, you can still achieve great things within clinics, for example, if the leadership of that clinic supports PrEP to that extent. And it really is exciting in Southeast Asia to see some terrific examples of clinics that are led by community key affected populations in Thailand, in Philippines with Love Yourself, and in some other settings, because you know, levels of HIV-related stigma and homosexuality-related stigma and stigma against transgender people are extremely high in Southeast Asia. And one good way of addressing that is to have clinics that are led by those key affected populations. And I think that's got a great deal of potential. I think the other things that really helped, I think, in the Australian setting was also the education of the community through the community-based organisations, because everywhere starts from a place of what's PrEP? I don't know what PrEP is. And that's where we were in 2015 or 2016. You really need to start with simple education. It does not need to be complicated, because PrEP is really quite simple. It's one pill once a day to prevent HIV. So we shouldn't let feelings that this is too complicated get in the way. And the same with professional organisations. Yes, we do need education of doctors and nurses and other healthcare workers about what PrEP is, but it's not something to be feared. PrEP is actually a relatively simple concept, and new guidelines coming out of the WHO later this year on further simplification of management of patients on PrEP, I think will be really, really helpful in this setting. And Michael, I think I'll leave it there.
Great. Thank you, Andrew. That was great. I think there's a lot to talk around PrEP for the region. Okay, we have a lot of questions, so I will start off straight away. I have a question for Danvik from Rita Widiadana from the Jakarta Post in Indonesia. And the question, Danvik, for you is, do you face any challenges when reaching out to the community with HIV testing services, given your conservative country? Do you have to face religious leaders or traditional leaders opposing your services, for instance?
Yes, we face those problems. I think in any country that has a conservative culture and views sex as taboo, we face those challenges where there are opposing factors on what, you know, on the things that we do, especially in offering HIV-related services, where they mistake our offering of sexual health or overall sexual health and wellness, mistaking it as, you know, as a challenge to rightful morality, or, you know, to challenge the status quo of each and every country. And it's really impounded on each and every culture of any conservative country. Yes, we have those challenges, but I think as service providers, especially in our organization, Love Yourself, I think what we are doing in terms of even though that there are opposing factors that limits our offering of HIV-related services, I think it's really important for us to be advocates as well in pushing for equal access to health, regardless of who you are. And that's what we provide in terms of providing HIV-related services. It's really not just to, you know, to provide the service itself, but it's really more of helping our clients to create that proactive management of health and wellness. And I think it's very important we could also work with them so that we could have an enabling environment for us to offer it. While it may take us a long route to, you know, to offer these services, I think it's really important to start these conversations we start these conversations of, you know, that having that perspective that we provide a health service and everyone has a right to access to health.
Great, thank you. We actually have some more questions for you from Sheila Crisostomo from the Philippine Star. She has two questions, Danvik. One is, you mentioned that unregistered self-testing kits are being sold online in the Philippines. How does this affect your country's efforts against HIV/AIDS? How serious is this problem? And the second question is, has the Philippine government or the Department of Health, Ministry of Health, adopted self-testing kits. Is this strategy already included in the Philippines HIV/AIDS programs? If you can keep, we have a lot of questions, if you can keep the answers as tight as possible, I'd be appreciative.
Regarding to the first question, it really affects the quality of HIV-related service, especially testing. I remember we have a client in our facility where he reported to us that he is HIV negative on his self-test kit that he ordered online, but he is actually HIV positive. So these quality of HIV testing that they receive from these kits that are actually not WHO pre-qualified really affects, of course, on how they should access the service. And it is a major problem, because if these simple events are multiplied in multiple, in multiple locations in the country, imagine those people who have who cannot receive the rightful services that they need to receive, that depends on their HIV status. And in terms of that, offering HIV self-testing also expands access. So what we did in Love Yourself is we established these experiences, and from these evidence that we collected in our demonstration project, we were able to present to the to the Philippines Department of Health and other stakeholders that this presents an evidence that we can roll out and we can offer HIV self-testing to multiple locations in the Philippines. So we are actually working on revising the HIV testing guidelines of the national government so that HIV self-testing will be included based on the evidences that were provided in various demonstration projects of self-testing that is not only provided in the Philippines but also abroad. So yeah, that's we are hopeful that self-testing will be offered legally in the Philippines.
Thank you, Danvik. The next question I have is from Jasmine Romero from ABS-CBN News in the Philippines, and it's directed to all our speakers today, but I might just focus on a couple of our speakers in particular, because the questions around, because we won't get time to speak to everybody, and we've got some other questions, but the question is around stigma and the reasons for stigma across the region, which I kind of think we've talked about a little bit, but I think the second part of the question about how stigma can be overcome and how governments can play a role in overcoming stigma, I think is a really, really interesting question. So I wanted to perhaps get Iskandar's view on that, and then perhaps Kritima's view on that, and then Danvik, you might want to wrap up as well. Go ahead, Iskandar.
Yeah, hi. So I think stigma is complicating. It's multifaceted. It is, it's internalized, it's enacted, it's institutional, it's organizational, it's at every level. And I think people are generally just afraid of what deviates from what people accept as conventional norms within the society. And sex plays a big part, sexuality plays a big part in it. And it's ingrained in sexual education right from the beginning. So countries which lack that sort of basis of sexual education earlier on, so clearly like Malaysia, which is still struggling with getting sexual education right after 20 years and is very conservative in its outlook, do particularly bad on scales of stigma towards key populations. On top of that, you have religion thrown into it, and it doesn't help things. So I think it's trying to find out the problems and gradually peel the layers and try and deal with in the solutions one by one. What I think with key populations that do help is visibility. What we have, particularly in Malaysia, that's lacking is, and so if you asked we asked a group of medical students and dental students on a scale of discrimination amongst key populations, who would you discriminate most against? MSM or gay men were very high up on the list, followed by transgenders, followed by people who inject drugs, and then subsequently HIV positive patients. So gay men within Malaysia had the highest rates of stigma scale. And I think the problem is visibility of what the perceived norms of gay men should be like. I think a lot of the perception is around gay men have a lot of unprotected sex, and that is the accepted norm, and they're irresponsible in how they approach sex. We do not have visible, educated, empowered, not empowered, educated visible gay men within occupations that are contributing to society. And I find that visibility a problem because it's a two-way, it's a vicious cycle. You come out, you declare you're gay, you know, and then there's a whole lot of stigma against you. But I think that visibility is important. And that visibility starts from very young. The openness of the environment to be able to talk about things and open, and also particularly health provided stigma, which is very prevalent. The introduction of medical curriculums that incorporate health issues around key populations also help to make a difference. And sensitization. I think sensitization to key populations across the region, particularly in Malaysia, is important. We could talk about this for an hour, but you know, I think that's the crunch of it at the moment from some of the problems that I see within Malaysia.
Thank you very much, Iskandar. Kridima?
Thank you so much. So Dr. Iskandar was touching on the education and sensitization, which is very, very good. So I'm going to share my experience from the experience in the Thailand, in Thai setting, about how the law can actually be a burden and doesn't help with the stigma. For example, here in Thailand, we don't have gender recognition law. And that means, you know, talking about education itself, we are unofficially not allowed to study to become a doctor. That I can tell you for sure. I mean, if you see any doctors who's a trans woman or trans man in Thailand, it means they start their transition after they finish their degree. They can't do it. They can't even get into it. And in my work, I have seen at least 3 people. One of them was a last year medical student that had to leave that medical school because she was a trans person and has undergone the gender assignment surgery. The other 2 were still, you know, students, and they face a big time difficulty trying to fit into the system where it doesn't actually facilitate a trans person to be in the faculty to become a doctor. And they also have this kind of mental health issue because of all the stress that they have and all the expectations from their family as well. The other thing I want to say is the employment. We still have a lot of stigma and discrimination against being trans person. For example, we can't serve in the military because they see us as someone with, you know, a gender sort of dysphoria that is still being seen as a kind of pathology, that we're still being sick. So it is not possible for us to join if you want to be, for example, if you want to be a soldier or police, I can't do it. And also with the no equal marriage here, for example, in Thailand, it means that our relationship is not valid. And as I mentioned earlier, that, you know, it has something to do, you know, with the index testing and how we can reach out to the trans, you know, partner, because we don't want to come out, we don't want to be, you know, bullied or questioned by the society. The other thing is the system about the Ministry of Public Health itself or the national health coverage. For example, in Thailand, we don't have any health coverage for the trans health at all. I mean, ideally, I always look up to England where they have the NHS and they have this coverage for trans people. I mean, even if it's a long queue for them, but at least they have somewhere that they can go. And they are valid, they are recognized by their, you know, government, by their country, but not in Thailand. We are actually not recognized, you know, we have never been seen by the health system in Thailand at all. And that is why, you know, we will still face a lot of stigma and discrimination going to the, you know, healthcare setting, as Dr. Iskandar has mentioned earlier, that we really have, it's true, it's happening, it's real, that we go to the healthcare setting and we still get, you know, lots of abusive, verbal, or kind of, you know, odd looks or get questions all the time. And if we sort of ignore this, if we don't address this, if we don't work together to actually, you know, have a closer look at this structural or, you know, the system, then I don't think we can actually end HIV, at least for the trans people. Thank you.
Thank you, Kridima. Thank you very much. And Danvik, you just want to talk briefly to Philippines?
Well, I think Dr. Iskandar and Gemma actually explained lengthily on how we can solve stigma from an external concept. But we need to also remember that aside from the external stigma that's dictated by the environment that we are in, there's also internalized stigma that is dictated on how we were lived to based on our culture, based on where we grew up. And if that internal stigma affects our decision in itself on how to for us to take care of ourselves better or to access any service or health or wellness service that we need so that we could love ourselves better. So I think one thing that I could add on, especially to solve internal stigma, is really to empower communities, especially communities that are closely knitted and they rely on each other as their safe space to listen to their peers, listen and share the best practices that they receive in order for them to take care of their health and wellness better. I think it's really important for that to empower them. First, empower them to, to dare for them to, to access services that they will be able to receive, and they know that it will make them better, so that they could know to take care of themselves better, and in practically sharing that concept of loving and taking care of yourself, as to share to other people so that they could empower other people as well, and you create that empowered community. And if there is already a collective community with a singular voice, we could raise it out and erase, or that's our hope, is to eradicate stigma that's really prevalent in our communities. We are still a long road ahead to that reality, but I think we should start somewhere. It's really for us to love ourselves better and share it to other people so that we could voice it out to millions of people elsewhere.
Right. Fantastic. Thank you, Danvik. I do have one question here from Sheila from the Philippine Star, and it's for Andrew, but I think I also want Nitya to answer the question too. And it's not almost something you've both specifically been talking about, but I think we'd all like to hear your views on this. And that's the issue around self-testing, which we've heard a bit about, especially from Danvik today. And the question's around, how important is self-testing going to be? If I'm interpreting the question correctly, how important is self going to be given where we've been with the pandemic, etc., going forward? Issues around misdiagnosis, accuracy, etc. But where is that going to sit going forward? So I wanted to ask Nitya first, and then maybe Andrew could follow up afterwards.
Yes, I'm during the preparation of this symposium, I actually was asked to talk about self-testing. And I was trying to avoid talking about that because we don't have any experience of self-testing in Thailand beyond the black market. Self-testing that Danvik already mentioned, and it has been like a decade of discussions back and forth to get self-testing to be legalized, and then finally it was legalized last year, not last year, 2019, and we will have the first HIV self-testing in Thailand market this month. So for me, I would foresee that certainly HIV self-testing will have its role in getting access to those out there who, even with key population-led gender-friendly clinics, still don't want to come out for HIV testing. That's one thing. Second thing is that it will allow people to test more frequently. Even though people who may come out sometimes to clinic for testing, they may want to check themselves regularly using self-testing. And then the third thing is that we certainly will have the opportunity to integrate self-testing into PrEP service. We still don't know how to do that, how to best integrate self-testing, whether that be oral fluid testing or blood-based testing in PrEP program. But I think you can stop people from, you can't stop people from doing that. Many people are already doing that, and many of us during COVID-19 period have already done something very similar to HIV self-testing to try to continue PrEP service. Yeah, so I just stop there. Listen to Andrew.
Right. Thank you. Andrew, what are your views?
Not really a lot to add, just to remind everybody that HIV testing is the absolute core. It's the gateway to treatment. It's the gateway to prevention. If you don't know you're positive or negative, you can't be treated if you've got HIV, and you can't access PrEP. So it's critical we have really high rates of testing among those people who need it. Now, there are parts of the world, particularly in Africa, where self-testing is very broadly used, and it's certainly recommended by the World Health Organization as an additional method of testing. Now, Danvik highlighted earlier today the problem with unapproved kits, and there are a lot of manufacturers around the world. And it's absolutely critical that we only use kits that have been approved by the WHO for use, because there are kits that are simply inaccurate. So, you know, it's very important that countries control the use of the tests in that way. In Australia, it's a little bit similar to Thailand. We have only approved the use of self-testing in the last few years. I think it may be about 4 years ago. We have limited access to self-testing, but we do it. And we have shown in studies that people who have tested very infrequently increase their frequency of testing once they have access to self-testing. So it absolutely has a place, but it needs to be well regulated.
Great, thank you. And I'll add one point, not about the region necessarily, but I do know, for example, in Eastern Europe, and especially in Russia, where self-testing has been an impossible thing to actually get across the line with a lot of activists and NGOs on the ground there. It's been really complicated to get people to self-test, but it's been curious that during the pandemic, there's actually been a huge increase in the amount of self-testing in the Russian Federation, which is kind of an unintended consequence, but it's curious that that's actually happened and been maintained over the last 12 months too. We have time for one more question, and I think we'll end here. If anybody, as I said earlier today, if anybody wants to ask questions of our panelists one-to-one after this event, please get in touch with me and we'll do our best to ensure that you can speak to them. The last question for today is from Milad of the Malay Mail, and the question is directed at Iskandar. And the question is, broadly speaking, Iskandar, around MSM, transmission and so forth. And I think Milad wants to hear from you, you know, very sort of brief points about what are the on-the-ground things that can happen policy-wise and implementation-wise to prevent transmission amongst MSM in Malay from increasing.
Thank you, Milad, for the question. So I think the situation when the Ministry of Health reported a HIV prevalence of 43% in Kuala Lumpur constituted a sense of urgency for Malaysia. The question was directed to the Ministry of Health, who provided some Ministry of, not Health, but Ministry of HIV, STI and hepatitis sector, and in terms of what could potentially be done. This was about three years ago when the data was initially released. There is a huge level of conservatism in Muslim majority Malaysia around sexual transmission and around sex, and that cannot be dissociated from the HIV response at the moment. I think a lot of Malaysia, a lot of the previous response in Malaysia, they're still sort of reveling on the success of the successes around prevention of transmission within people who inject drugs. And Malaysia's done an amazing response, but as a result has had a delayed response to sexual transmission of HIV. What collectively as a group we've been trying to do and work with the Ministry of Health is to scale PrEP up. But unfortunately, it's mainly now in the private sector. We do want to extend it to the public sector because you need to get that coverage up. Otherwise, you're not going to impact on HIV incidence. But currently, the focus is to scale up PrEP within the private sector, mainly to ongoing negotiations to make a unified price for all private sector clinics, which the Ministry of Health can get. So a very reduced price, but extended to private clinics. We've moved towards quicker antiretroviral initiation, not quite same day art. I would love if we could do that, but there is some hesitancy towards that. There is a pilot project of HIV self-testing. Like other countries within the region, we've been very slow to take that up, but things are moving forward with that. So more HIV self-testing and slow but gradual empowerment and increase in some domestic funding for key populations, especially when it comes to testing. So I think those are some of the key responses to addressing the sexual transmission, particularly within MSM. More could be done, definitely. I think we just need to keep on pushing the right people and making them hear our voices.
Great. Thank you very, very much, Iskandar. So with that, we've been able to answer everybody's questions, which I'm happy to say. As I say, if you do want to follow up with any of our speakers, please let me know. And also a reminder that we will send you the link to the recording of this media briefing today. I think we'll all agree that it's been very, very insightful, and we could keep on talking as the questions roll in. And I would like to thank our wonderful panel for being here today and committing to this, and also to the journalists who are sitting in the audience and also being great and asking lots of questions. So once again, thank you very much. Enjoy your evening, and we will see some of you again tomorrow when we talk about the impact of the COVID pandemic on the HIV/AIDS epidemic in Southeast Asia.